issues that we're dealing with more and more in Nigeria. Okay, so this afternoon, you're going to be telling us a bit about heart failure. And a lot of people are concerned about this, especially with the amount of hypertension and other related conditions that we have in Nigeria. And of course, there are many cases I can put in mind. Okay, but the case we're going to mention this afternoon is someone that we saw recently, and that's a young man, a 34-year-old man. He presented with shortness of breath. Of course, he had some autopnea, he had some retrosternal pain, and that developed over the last almost 1 year. Okay, but his symptoms actually got worse, and he started having the shortness of breath, waking him up at night recently. He had a bit of cough productive of mucoid sputum, and then while he was talking to me in the consulting room, even just making a few statements, you see that he's already panting a bit. He has not used alcohol or tobacco in the past, and he gave an interesting history, the sad history though, of his brother dying of heart disease in his mid-40s. This is a 34-year-old man. Now, when I saw him, when I examined him, he was conscious and alert, and he had pitting pedal edema up to the upper leg. His pulse rate was small volume, 110 per minute. The blood pressure was 123/91 millimeters of mercury. And then on examining his chest, it was breathless at rest, respiratory rate of 24 per minute, but the chest was clear on auscultation. Wow. What do you make out of this kind of presentation?
So this is like a typical presentation of heart failure. One of the cardinal features of heart failure is the presence of difficulty in breathing. By the time somebody is having difficulty in breathing, he must not only think of COVID. Okay, so COVID is one of the things that everybody talks about and thinks about. But you must not only think about COVID, you should also think about heart failure. And difficulty in breathing is one of the key things in heart failure that comes about. Now, the difficulty in breathing in this case is one that is typical of heart failure, that is slowly progressing. Remember, slowly progressing difficulty in breathing, dyspnea and exertion. And that's one of the key things and that talks about that is in heart failure. So slowly progressing difficulty in breathing. I think you shared the slide. Resume share. So he said he has PND. Now remember that in heart failure, go back please. Remember that in heart failure, paroxysmal nocturnal dyspnea, which means they are waking up suddenly at night once in a while, is one of the signs or the symptoms of heart failure that is quite specific. It may not be there in every person, but when it is there, it's something that gives us some pointer towards heart failure, very important. So those are some of the things that we'll look at. Now, if you look at the case also, you will see that diastolic blood pressure of 91 millimeters of mercury. So don't say that this patient is not hypertensive. Once you see greater than 80, greater than 85, then you think that it is from heart failure.
Okay. Now, when we did run some labs for this patient, and so there's a typo there. Okay, but the N-terminal pro-BNP, which is a heart failure marker, was actually quite elevated. The N-pro-BNP was over 6,000 milligrams per DL, and the cutoff is usually less than 300. Also, the troponin T was done to look for evidence that could suggest a recent myocardial infarction, and the troponin T came out to be normal. He also did have a cholesterol panel done, which actually showed that he had quite some dyslipidemia. His total cholesterol was actually 357 milligrams per DL, whereas the LDL was 307. Those are both quite high. And in the context of the family history in the brother, will actually make me wonder whether this guy actually had some sort of familial hypercholesterolemia going on. Apart from that, he actually also did have hematuria and proteinuria on urine analysis, and the serum creatinine was 1.1 milligrams per DL. Beyond this initial lab test, of course, he had some imaging done. I'm not sure what your comments will be on those initial lab tests before the imaging was done.
So this is a very serious case and very well evaluated. You can see the N-terminal pro-BNP. If you are ever not sure of heart failure cause or difficulty in breathing cause, one of the tests you can easily order is N-terminal proBNP. Most big labs should be able to do it. If you're in Abuja environment, you can send to Cardiocare. And typically, that is typically like the heart failure enzyme. And it's something to always look out for. Now, you will see that the troponin is negative, which kind of helps you to rule out or to at least get your mind at rest, because they said he had chest pain, whether this is due to myocardial injury. Okay. Now, having said that, this is a complex case and it's one that is likely not just heart failure, because you can see the amount of blood and protein in the urine, which means there's probably a nephritic syndrome ongoing here. So this is quite a serious case, and we'll probably talk about it. And the role of evaluating comorbidities in the management of heart failure is quite critical in every management of heart failure. Now, if you look at the echocardiography and the other findings, you can see an ECG, a normal ECG in heart failure will almost always have you re-examine whether the diagnosis of heart failure is correct. And that is why you can see the ECG is abnormal. You can also see that the echo also shows global hypokinesis. Now, interestingly, is the age of the man. In this part of the world, heart failure is said to happen at younger ages, and so this is something that we should worry about. And dilated cardiomyopathy is also common, and this is something that we should worry about. So, but we'll just go on to other things straight away.
Okay, so we're talking heart failure now, and that this looks like a syndrome of heart failure, but a lot of people think that it's actually until someone is dead that the person's heart could be said to have failed. So what is this heart failure thing itself?
So heart failure essentially is defined in several ways. But heart failure does not mean that the heart has stopped working. Heart failure means that the heart is not able to work and meet the demands of the body, or is only able to do so at an elevated filling pressure. So that means that the heart is pumping, is not able to meet the demands of the body, and the person definitely gets signs of showing that the heart is not pumping enough to go around the body. That's number one issue that we noticed there. The second way you can define heart failure is that it is cardiac dysfunction that occurs at rest or during stress. So sometimes you have people that have heart seemingly working well at rest, but sometimes also it occurs only during stress. And that is why some people have decided to define it as either or both.
So I'll ask, is it every heart condition, every heart disease that can lead to heart failure, or is just a few heart conditions can lead to heart failure and then some cannot lead to heart failure? What would you say about that?
So generally, it is said that heart failure is the final common pathway of almost all cardiac conditions. So whether it is dilated cardiomyopathy, whether it's a valvular heart disease, whether it's congenital heart disease, whatsoever is affecting the heart almost invariably leads to heart failure, which is actually a chronic progressive syndrome. It's a syndrome that relentlessly continues and seems to potentiate itself. As it starts getting worse, and it kind of just potentiates itself, especially when there is no intervention. So those are the things we should wonder about.
Okay, so but now you did mention dilated cardiomyopathy, you mentioned hypertension and ischemic heart disease. What are the other things that typically cause heart failure?
Okay, so heart failure essentially in Nigeria, the predominant cause, of course, is hypertension in Nigeria. So here in Cardiocare, we've been doing a lot of angiographic studies, and of course, it makes us, we have able to look at different causes in terms of ischemic heart disease, but still hypertensive heart disease is still the leading cause of death, especially in this part of the world. So valvular heart disease is also one, but it has seemingly reduced, especially in most parts of the world, including Nigeria. And in Abuja and most metropolitan cities, valvular heart disease, which essentially mostly happens from rheumatic, is reducing in origin. So hypertensive heart disease is typically the most common. We have dilated cardiomyopathies typically coming in almost second. We have ischemic heart disease. Then we have valvular heart disease. Then we have other things, arrhythmias, congenital heart disease, endocardial disease, overload. All those are things that could seemingly cause heart failure. However, we must always remember hypertension, coronary artery disease, dilated cardiomyopathy, and ischemic heart disease.
Of all the cardiomyopathies, would you say that dilated is probably most common we see in our environment?
Yeah, definitely. Now, of course, dilated cardiomyopathy may be the end spectrum of most diseases. So
Okay.
sometimes people may even have hypertensive heart disease, and in the end, when we are seeing them, we see there's no history of hypertension. All we see is a massively dilated heart, unable to walk, and idiopathic dilated cardiomyopathy is definitely the most common. There are other types, restrictive hypertrophic. We have a number of patients in Cardiocare that we are managing for hypertrophic cardiomyopathy, some with diabetes, some with other issues like you know about. However, direct cardiomyopathy is almost always the most common ones, and it also has a role to play. The reason, one of the things that is postulated, that is a viral origin, and so of course in our environment where infections are high, some of these things have been thought to play a big role.
Okay, so how does a heart get from being normal, or maybe perhaps slightly faking by hypertension, then to frankly failing? How does a heart get from normal then to fail? How does that failure really develop?
So the pathogenesis or the pathophysiology of heart failure essentially is such that, especially in hypertension, is such that first the heart tries to cope with the severely elevated blood pressure. It tries to change its body. It tries to what we call remodeling. It tries to give extra muscles, change its shape, collect the pressure, get diastolic dysfunction so it's unable to relax, all in a bid to cope with that high pressure. So imagine that you have a pump in a house that is pumping against high pressures in pipes. After a while, for that pump to continue pumping well, it has to change its infrastructure. That's essentially what heart failure is. And that is ventricular remodeling. What then happens after ventricular remodeling? Please go back to that slide. What then happens to ventricular remodeling, which is injury to myocardial infarction due to heart failure, due to hypertension, infarction? Electrical instability occurs, ejection fraction starts to diminish, or the heart is unable to pump to meet it. And then the cardinal central point of heart failure is neurohumoral imbalance. This is the bedrock of the pathophysiology of heart failure. It is because of this neurohormonal imbalance that people are unable to just get out of heart failure. Next slide. So people are unable to get out of heart failure because of that. There are three neurohormonal systems that essentially govern heart failure. You get these three in order, you are, you are a cardiologist. We'll give you a cardiology degree. So essentially, one is the RNA system. Two is the sympathetic nervous system, and three is the natriuretic peptide system. All of these systems were designed ab initio to help protect the heart and improve the heart function. However, after a while, it begins to worsen things, and make things not as clear, not as effective, and begins to go back now and cause damage. So essentially, this now becomes the target of treatment, the target of research. Unlike before when we're talking about the dioxin and
So what you're saying is that these neurohormonal changes they actually try to help initially, but later they worsen the problem. That's actually quite interesting. Does it mean if they are helpful initially, does it mean that if we interfere with them or if we intervene with them early, does it mean that we're worsening the condition?
Well, essentially, we're not worsening the condition, but what it means that by the time you interfere with them early, you are actually going to save the heart. The patient will probably become symptomatic initially, and then we now take it from there. So what essentially happens is that those things start, the renin system, renin angiotensin try to kickstart it. At that stage, patients typically don't show anything. It's also even very difficult to pick it clinically. All you can pick at that stage is the precipitant. And what should be the aim of treatment will not be the RA system, will be the precipitant of the heart failure.
Absolutely. So, but now, heart failure, I know it's a very broad thing. I've seen a lot of heart failure patients. I would say that hardly any two are the same. Is heart failure just heart failure? Or are there the subtypes? How do we classify heart failure?
Okay, so to classify heart failure, there are different modalities of classifying heart failure. And one modality of classifying heart failure is by ejection fraction on echo. So on ejection fraction on echo is typically divided into three types. The fact that the patient has a normal ejection fraction does not exclude heart failure. So I see a lot of physicians or doctors just take an echo report and go straight to ejection fraction and say ejection fraction is normal, so therefore you don't have heart failure. No. So that is something we should know. Ejection fraction being normal does not exclude heart failure in any way. What essentially you have to do is that you need to look at ejection fraction. Sometimes it could be mid-range, sometimes it could be normal, sometimes it could reduce. The second kind of way is whether it is acute or chronic, and that is how they present clinically. That's the way to classify it. Another way, and which is the most common way that has stood the test of time, is the NYHA class. And that NYHA class has stood the test of time. It has been there since 1981, when it was postulated, I think by Ross et al. And that NYHA class just classifies how severe is the difficulty in breathing. This is the basic thing we have been taught in medical school, but it's still one of the most critical ways of defining heart failure, deciding what kind of treatment, and deciding prognosis. And of course, sometimes you can use the ACC or AHA stage.
Okay, so before we go further, I think we would like to take a poll, and we'll try to see how much our audience is familiar with the NYHA classification. So let's try to take poll 4, and let's see. So let's see our audience how much they can discern the answer.
A 66-year-old.
A 66-year-old man was admitted with shortness of breath, cough, and pedal edema. Which of the following is most consistent with NYHA class 3 symptoms?
Let's try and answer it. Yes, I'm seeing people are answering.
NYHA class 3, which one is most consistent? Most consistent, NYHA class 3. Okay, let's just wait for another 10 more seconds. So we'll see where we settle at. Okay, thank you for participating. Let's end the poll. Let's see how people chose. Okay, so I think that most people chose the most correct answer. I'll leave Chief Iseko to comment on it.
So generally, during the NYHA class, some studies have tried to create an algorithm to help you classify it. But essentially, if you go to the slide, you see the NYHA class. So NYHA class is classified into 1 to 4, essentially class 1 to 4. Every time you make a diagnosis of heart failure, you should try your very best to give NYHA class. You should try very best. And so class 1 simply means that there's not much symptoms. Patient is fine, in short. Just that we know that they have heart failure, they have the symptoms, they have the signs, they have become class 1. Yes. Class 2, essentially, there's slight limitation of activity. Sometimes when they climb one flight of stairs or activity that they would have done normally, they will now start feeling extremely breathless. Class 3 is normally when they do mild things. So it's marked limitation of ADLs, activities of daily living, just like in the poll now. Dressing up, they quickly feel breathless. And class 4 at rest, as in they don't even have to do anything, they are already breathless. And that is a very critical and a marker of severity in terms of heart failure.
Okay, thank you for that. So, of course, we all know the typical features of heart failure. The patient we presented actually had some of those symptoms: shortness of breath, cough that is often worse at night, maybe productive of frothy sputum. Sometimes you can have autopnea. You can also have the PMD that you mentioned that is fairly specific for heart failure. And sometimes, of course, people can have palpitations. They can have edema of the extremities. And but when we examine a patient with heart failure, what signs should we look out for?
Okay, so when we're examining a patient with heart failure, there are a number of things you should look out for. The first thing you should look out for are signs of the cause, C-A-U-S-E. And the next thing you should look out for are signs of the cause, C-O-U-R-S-E. And the third thing you should look out for are signs of complications. So the 3 C's essentially.
Absolutely.
So to look at for the signs of the cause, essential of the heart failure itself, you'll be looking at just like I see on the slide or top. Next slide, please. Of this for the that slide. So edema. Sometimes they have jaundice. They have hepatomegaly. They have a raised JVP. Sometimes people have forgotten how to check for JVP, and it's hardly done. It's not only in medical school, but when you get down to serious cases and you really need to tell, especially if you don't have all the gadgets that maybe is available in top hospitals or perhaps specialized hospitals like Cardiocare, you probably have to go down to those things to be able to decide it. So those will help you tell you that this is heart failure. And of course, a third heart sound if you can hear that. Now, the next thing, of course, is the signs of the complications. And sometimes you start seeing jaundice, you start seeing jaundice, you start seeing patients can come with a stroke, they can come in with dusky extremities, in which case maybe there's been a clot in the heart that has gone far. Sometimes they could start coming in with symptoms of renal failure, you know, and all of that. So those will also come into play. Now, remember I said you should look at symptoms, signs of a cause. You should also start looking for blood pressure. You should also start looking for signs of long-standing hypertension, displayed apex. You should also look for thickened arterial walls, all those things that we were taught in medical school, including retinopathy, doing a fundoscopy. All that will help you give you a time tail. So when you say about diabetic cardiomyopathy, you cannot just say diabetic cardiomyopathy. If you've done this, you can now say that this is maybe the end result of diabetes, hypertension, or something else.
Absolutely. Thank you very much for that. Before we go for that, I'll try to remind our audience that we should post questions in the Q&A box. We'll address them later along the line in the presentation. And that input is actually very key to the discussion. Now, so we've talked about the signs and symptoms of heart failure. So, of course, I described a man that came in earlier on and had a panel of tests done. If a patient comes with a clinical syndrome that is suggestive of heart failure, how should we approach such patients? What investigations should we do? What should we prioritize? How can we make sure that we do it without leaving any stone unturned?
So thank you very much. So heart failure is really one topic that is very dear to my heart. And we have over 180 people on this Zoom call. So I'm very happy that we have almost 180 people actively listening to heart failure. Now, when we want to investigate heart failure, there are some tests that we should do. An N-terminal pro-BNP is one that helps. You can use it, especially when you're unsure. And sometimes you can use it to follow up. In these days of COVID, it can really help you to, navigate whether it's heart failure. We had a patient recently, who fall into almost every classification. So sometimes even for specialists, it can be very difficult. But when we did the N-terminal pro-BNP, it was greater than 9,000. And then they could tell us that the primary underlying thing was heart failure. Remember that sometimes some of these enzymes will also be raised in COVID. Troponin, D-dimer, pro-BNP sometimes. But when you now see greater than that, the cutoff for N-terminal pro-BNP is normally greater than 60, greater than 300, and for the pro-BNP normal is a little bit higher. But we are used to using N-terminal pro-BNP, which is a little bit more sensitive than the normal BNP enzyme that is being done. Now, an ECG is mandatory. You cannot manage a patient with heart failure without having an ECG.
But we can, even though we can't diagnose heart failure with ECG, but we definitely have to have an ECG.
Exactly. And the reason is twofold. Number one, it helps you to tell maybe the cause of the heart failure. And number two, it helps you also to determine if there are complications for that heart failure. And sometimes, number three, it helps you to tell you what are the precipitants of that heart failure. And if you don't take care of it, that patient will never get well. So you must do an ECG. There is no going out of it. Number three, you must do EUCR, because of complications, especially patients on diuretics, and a lot of times, some level of what we call cardiorenal syndrome occurs. Okay, there are different types, but we're not going to that. But cardiorenal syndrome essentially means that the heart is not pumping enough fluid, enough blood to the kidneys, and the kidneys interpret that as a problem, and you have an acute renal shutdown. And so EUCR is very important. Chest X-ray also to help exclude other things, full blood count in terms of anemia that could worsen. Go to the next slide. In terms of other things that could worsen it, and then echo. Must you do an echo? The answer is yes. The answer is yes. There is no role for managing a patient with heart failure without an echocardiogram.
I remember a patient that was sent in at one time with what seemed to be a fairly rapidly developing heart failure, and they actually started him on medications. But by the time we did the echo, I know that, he had a very significant pericardial effusion that actually had to be drained. And this is someone could have been managing for heart failure just because he had some heart failure-like symptoms. So I absolutely agree with you that the echo is actually critical in managing heart failure patients.
So I know that there are a lot of resource poor areas, and I know that some states have severe limitations in getting it, and we know that we're talking to most of the country. However, do make sure that the patient gets at least an echocardiogram. It helps to coordinate treatment. It helps to look for other things that could be masquerading. It helps to look for pericardial effusion. It is invaluable in the management of heart failure, so you must do that. TSH and thyroid function test is recommended in all cases of heart failure. That is the guideline. However, it's not almost always done because, you know, funds. But I remember that I had a patient about 4 years ago, heart failure symptoms, heart failure diagnosis. Echo was neither here nor there, especially when the patient has a normal EF. And we looked for the cause and I could not find any cause. Then I noticed a small neck swelling, and for the next swelling was not much. We just did the thyroid function test and I saw how bad it was. Next thing, we started managing the hyperthyroidism and everything came back down. And sometimes you could manage heart failure for so long when you could do that. The second reason why you do thyroid function test, especially if the patient is on anti-arrhythmic drugs that could modify thyroid function. Okay, that Holter ECG is quite important, especially to assess risk of death. And then the other thing, don't forget to do COVID tests, because sometimes patients with breathlessness could have heart failure, and nothing stops patients with heart failure from having COVID. So you should remember that. Then, of course, an echo. Now, if you have an echo, what should you look out for as a doctor? There are some key things you should look out for. Number one, you should look at the chamber size. Look at that LVIDD, the left ventricular internal diameter. Don't just gossip any echo result. The next echo report you get, look for it. It will be there if it is a proper echo that is done. So look for it. The any LVIDD greater than 5.6, you should begin to worry that this heart is getting enlarged. It is a recommendation by a lot of people, and in the school of thought where I train, that everybody that has hypertension should have echocardiography. I can see somebody ask the question about should my hypertensive patient have an echocardiography? The answer is yes. Okay. Now some people say if they don't have money, okay, if they don't have money, let it be that they don't have money. But don't on your own take that decision. So number one, look at the chamber size, look at the valve function, ejection fraction. Remember we said it helps us to differentiate the levels. Then try and look out for the E over E prime. E over E prime. It is a figure there, it is a ratio. That E over E prime, if you don't know whether it is heart failure or not, especially in cases where the ejection fraction is normal, and E over E prime greater than 15 typically indicates a significant problem with atrial filling. And so that can cause a problem in general. Yeah.
Okay, thank you very much for that. So I think you mentioned that in terms of imaging, ECG, echocardiography, and perhaps chest X-ray is useful. And then, of course, a whole barrage of blood tests are also necessary as well. I'm happy you did mention the thyroid function test, because both hyperthyroidism and hypothyroidism can actually affect cardiac function and can make it difficult, particularly if it's untreated, for a patient with heart failure to recover, make the recovery very difficult. But when we have this kind of heart failure patient, particularly putting your mind back to our first patient I described, you know, we talked about that young man that came with heart failure symptoms over the last 9 months, and then the heart was dilated on echo. How should we approach the management of these patients? How should a patient with heart failure be treated? Briefly, I know that we have limited time, so we can't go into all the details, but just briefly, sir.
Okay, so the first thing in my mind is to counsel. Please, please, please. This is the most important thing, both in heart failure and hypertension. And we'll be delving deeply into hypertension. Dr. Olalekan has been doing press up with hypertension topics. So we'll delve deeply into it. Take time and counsel. Heart failure has even a worse prognosis than most cancers. So it's not something that you just say, take this drug and then you stop and you tell them to go away and they stop the drug after some time because they are feeling better. No. This is one of the most important things that you must do. Start counseling, counsel, and educate. Now, don't just educate the patient, try to educate the family as well. So there are times when in Cardiocare, we ask the patient to go and bring their family. And there's a role for a heart failure nurse or in education to follow up, social worker to follow up. Now we'll now treat the heart failure syndrome. And the process of treating heart failure syndrome involves reducing preload and afterload, identifying the precipitants and treating them, but very important and critically, to treat the neurohormonal abnormality. If you remember, at the beginning, we thought that the neurohormonal system is the cardinal thing in the management of heart failure. It is the cardinal thing in the management of in the pathophysiology of heart failure. So you must treat it. If you are giving patient drugs and you are not addressing the neurohormonal problems, you are going to make the patient feel better, but the patient will probably still die within 1 year. So you must treat them. And then sometimes you may need to consider direct improvement of contractility, although this seemingly doesn't have so much effect. So typically reduce preload after load, and treat neurohormonal abnormalities. Then in advanced heart failure, consider improvement of contractility, especially with the use of devices. Treat the etiology. That blood pressure must come down. If the patient has a blocked artery, send them to where the cath lab is, just like Cardiocare has a cath lab, and it's one of the only, in fact, it's not the only functional cath lab in the northern Nigeria. Send them where they have a cath lab. We check the blood vessels, we open up any stents, then optimize other cardiovascular risk factors. Don't forget that there are other things. You must take care of the diabetes. You must take care of the blood sugar, of the kidney function. You must take care of the cholesterol. You must take care of all of that. Now, if the patient is coming acutely, treat the precipitant. Remove that precipitant. If you don't take care of the precipitant, that patient is not going to get well. That precipitant could be a number of things. Maybe we'll talk about that later. And then if there are other comorbidities, you must treat them because they have an impact on heart failure. If the patient needs a device, please get the patient to a specialist that can put a device as soon as possible. If you don't know one, of course, Cardiocare is here, we can do that. Now, monitor for clinical progress. Don't forget quality of life. Sometimes we as doctors just give drug and forget to ask the patient how they are doing, how they are relating with others, and then begin to plan for long-term multidisciplinary and cure. These are the general principles. Perhaps we'll go into some specifics later.
Thank you for talking about those general principles. My mind is lingering on that precipitant you mentioned. What are the common precipitants that we see for this heart failure?
Okay, so the common precipitants that we see for the heart failure, essentially in this environment, is to find out is arrhythmias, chest infections or infections generally. Sometimes severely elevated blood pressure could be a precipitant that a lot of patients come with. And so that is something that you need to find and treat. If you don't take care of the precipitants in the heart failure, you are not going to get out of it. So we have arrhythmias, we have infections, we have elevated blood pressure, we have thyroid abnormalities.
And then sometimes those patients, they take some medications that they ought not to take.
Exactly.
NSAIDs, caffeine.
So sometimes patients have taken other drugs. You need to ask. Yeah. So, you have volume overload. They had diarrhea. They rushed to one hospital. They rushed them fluid. They are now filled up with fluid. Sometimes it is dietary indiscretion. They took food with a large amount of salt. They went for a party. They ate, and then dietary indiscretion, drugs. Sometimes it could be a new onset heart attack. So sometimes the patient could be having. So anytime you have a patient coming with sudden worsening of heart failure, you also have to check, is this patient having a heart attack? So evaluate. That's why the ECG is mandatory.
Absolutely.
Every time a patient has a worsening one, she must do an ECG, you must repeat an echo. And those are some things that you must evaluate.
Okay, well, I'm not sure how much of the nitty-gritty of the heart failure management that we're going to go into. But I'll first of all ask you, what has really changed in the last 5 to 10 years in the management of heart failure, particularly in Nigeria particularly?
So I will generally focus on neurohormonal. So somebody was asking about what are the neurohormonal things that need to be treated. One of the most things that have changed in general heart failure over the last 10 years has been the change in the pathophysiology of heart failure. And the pathophysiology, before somebody would say heart failure, give digoxin, give furosemide, and give Sloke, and then they say that person is fine. But that most times doesn't affect mortality. These drugs that affect mortality are the ones that affect the neurohormonal system. And they are essentially beta blockers. The beta blocker helps to bring down the sympathetic nervous system, reduce the heart rate, allow the heart to feel. Now, when I was in medical school, if you say beta blocker in exam for heart failure, you have failed. You are coming back. But of course, now that has changed. Yeah. If you don't say beta blockers now, you have failed because it's unheard of for you not to introduce beta blockers in the management of heart failure. So the other thing that you need to take care of are the RA axis. What are the things in the RA axis? You need to give an AC inhibitor or an ARB or an ARNI, angiotensin receptor neprilysin inhibitor, which is quite a new one. You cannot give these drugs together, especially the ARNI. You cannot give it together with another drug. Please don't ever make a mistake. In fact, if you are changing to any of the ARNIs, you probably have to stop one of the drugs for a long time, especially if it's an ACE inhibitor, for almost 36 hours so that there's a washout before you now put it in. Now, the other thing that spironolactone has always been around, we've always used it, but you must use spironolactone. People say spironolactone is also a diuretic. No, it's not. We're not using it as a diuretic in this sense. Typically, the low dose of 25 milligrams is enough, and you are using it as an antagonist to aldosterone. It cuts off that RA axis. You have given your ARB, it cuts off the angiotensin. You are giving your aldosterone, it cuts off aldosterone. Now, in addition, spironolactone also helps to reduce fibrosis in the myocardium. So, part of the things that happens in heart failure is that PDGF, platelet-derived growth factor, and also other factors that increase fibroblast growth factor, all go and cause deposition of fibrin and fibrous tissue in the myocardial tissue. And angiotensin antagonists, aldosterone antagonists are invaluable. Also, isosceles hydrolysis, which is not being used commonly in Nigeria, for some reason, it has not taken off. Yes, there have been studies done. Olga et al. Has done some studies, but it has not really had its place in Nigeria, perhaps because pharmaceutical companies are not moving it as much, and there's no single drug. And then Ivradrabi, which we use in Cardiocare, also can be used, especially in patients that are not able to tolerate beta blockers. Okay.
So, when should a patient come in for admission? What will be the indications for inpatient management in a patient with heart failure?
So the patient comes to you and is breathless, and he comes to you and say, like one man told me, Oga, one thing I've just noticed, we say, I know if you climb woman the way I feel climb woman. I had to stop. I had to stop the conversation to laugh. We laughed together, of course. But one of the things you need to consider for admission when a patient is having acutely worsening of their symptoms, where NYK2 before and they suddenly become NYK4, they become NYK3. Anytime patient is NYK3 or 4, it's typically a time when you should consider bringing them into the hospital. Now, don't forget that the number of heart failure related hospitalizations has a big role to play. Sometimes when they have new or intercurrent problems, they have an MI, they have pulmonary embolism, they have DVT, they have an infection, or they have, or when sometimes you want to start a new therapy, sometimes you have to bring them in. Oftentimes when we want to every time when we want to start a new therapy, we have to bring them in, especially the ARNIs. When you are afraid that hypertension could happen, sometimes even patient anxiety is an indication for admission, and you need to take care of it. Occasionally also, when you have cardiogenic shock or when patient is unable to mobilize fluid, then you need to change to IV. You need to sit down, and during an inpatient admission, you need to find out what are the precipitants and address them. And when patient is not responding, and then patient requests.
So I would like to ask, what are the things you consider the main challenges in managing a patient with heart failure? You mentioned the blood pressure now, which can be often low sometimes and make things very difficult. What are the key challenges that are there in managing a patient with heart failure?
So one of the key challenges, especially in Nigeria, number one is making diagnosis. Because that's why we are having this ACS 2020. First, you have a patient coming with difficulty in breathing. It has been getting worse over time.
Or fatigue.
But when they sit down, they are fine. When they do something, they get breathless. You need to evaluate that patient for heart failure. Okay? You have patients with hypertension, you need to evaluate. So when you notice that and you're able to take diagnosis, you've done your BNP, you've done your ECG, you've done your echo, you've evaluated them, you've given them an NYK class, that's normally the first problem. The second challenge that you have now is making sure that you have the right investigations. The third problem you have is identifying the comorbidities. The fourth problem you have is knowing when this patient needs device therapy. Because if they don't get device therapy in time, they could die before their time, even though they are the correct drugs. Okay, so sometimes these are the key challenges that we face. And sometimes the problem is that not even identifying the precipitant. So the patient can be coming again and again and again. So sometimes we have this kind of patient comes, they say the patient has been somewhere before, they are managing for this and he's not getting better. We go back again. Then you look at the ECG a second time and you see an atrial flutter or one dysrhythmia or the other. If you don't address that abnormality, you probably will go nowhere with that heart failure. So that's some of the challenges that we find.
Just for the sake of our audience now, I'll ask. So I'm a GP, I'm managing a patient in certain settings, and I think the patient may have heart failure. Maybe I give some medications almost empirically, and perhaps the person got a bit better. I don't know, but when should a GP refer a patient who has a clinical symptom that is suggestive of heart failure?
So a lot of people are wondering, will be wondering, why should I refer? Why should I refer? Heart failure, remember I told you, has an equivalent mortality to cancer. Every heart failure patient should ideally have at least one specialist consultation. and should invariably be managed with a specialist. So you should at least get them to a heart failure specialist. They can go back to the GP for follow-up and get back to the heart failure specialist from intermittently. And then there are times when the GP must now follow certain guidelines and things. Of course, there are some things we consider during when admitted and other issues, but really every patient that has heart failure, please get them to a specialist. There are some things that not everything can be taught. But before you do that, you can start taking care of the precipitants, take care of the blood pressure, take care of commence something that affects the neurohormonal system, and then of course, before you cannot get them to specialists.
Before we go on, I think we should take the next poll. I'm not sure of the question that is there again, but let's just take the next poll. There's the last poll there. Okay, so I think we've gone through this part already, but I'll just read the question out. Concerning investigations for heart failure, which of the following is true? It's based on the things we said. I trust that our audience have been following. A normal X-ray largely excludes the diagnosis of heart failure. Hyponatremia and hypokalemia worsens outcome. A normal pro-NT-BNP largely excludes heart failure. A low blood pressure makes hypertension unlikely to be the cause of the heart failure. So let's see how our audience chooses.
Wow, this is good.
Okay, I think you delivered the message very promptly. I think that's I appreciate you for that. That's great. That's great. I think we can end the poll at the dot of a minute. Just once a minute is completed, we end the poll. And then just share so that the audience can see the result of the poll.
All right. So which of the following is true? A normal chest X-ray excludes heart failure. Largely excludes heart failure. Not necessarily true. So I will not say that's true. So I'm happy that not many people answered that correctly. Hyponatremia and hypokalemia worsens outcomes. Definitely, hyponatremia worsens outcomes. The management of hyponatremia and heart failure is a very, very difficult one.
Absolutely.
And it's something that you need to take very carefully. Because you cannot give sodium, and if you do so much so, and there are roles of several drugs called the Vactans, a normal pro-BNP largely excludes heart failure. Now that is controversial. To a large extent, it does exclude heart failure in about almost 90%. But remember that largely, so the answer is true. So remember that 5 to 10% it will be normal, and they could still have heart failure. That is why low blood pressure makes hypertension unlikely to be the cause. That is false. So please, that is false.
Okay, thank you.
So by the time your patient is presenting with heart failure, they could have a low blood pressure. It doesn't mean that hypertension did not cause it. It just means that at that point in time, the heart is so weak that it's unable to pump.
Absolutely.
So it's not as if blood pressure did not cause it.
Okay, we have very little time left, more, Dr. Iseko. I know that many of the audience are fairly familiar with the role of ACE inhibitors, ARBs, spironolactone in the management of heart failure. So I think we'll talk a bit about the role of a cath lab and devices. We'll talk a bit about the harness and maybe one more aspect of it because of time. So let's go to the cath lab now. What is the role of a cath lab in the management of a patient with heart failure?
Okay, so in a patient with heart failure, there are a number of things that we can do in the cath lab. One of the key things that we do in Cardiocare is take the patient to the cath lab and determine if there's ischemic heart disease. World over, ischemic heart disease is still the #1 cause. And there's a lot of people that speculate whether ischemic heart disease is also the #1 cause in Nigeria, but because we have not been going to the cath lab, we don't know. So sometimes, especially we think that there are clinical indications or things that could worsen it, or raise troponin, or a suggestive ECG, we typically go to the cath lab, to have that. Now, besides that, we'll now talk about device therapy. A lot of patients need device therapy in heart failure, and they are not getting it. And this is where a lot of work has to go in. In Nigeria, I think less than 50 devices, cardiac devices, are put in the entire country. That is,
I think people are not used to the fact that these kind of things are available. I would say that when I was in maybe medical school, even during early residency, they were actually not part of the things we had. Okay, it's almost like insulin in diabetes, but people need it, and people should get it because they need it.
Yeah. So most times we put in devices and it helps. Resynchronization devices, we put in one last week, really changed the course of heart failure.
Absolutely.
It increases the length of life and increases the quality of life, especially in patients that qualify for it. Now, in patients with, there are indications for putting different devices. If a patient has bradycardia, that is their heart rate is too slow, they need it. If they're less than 40, they typically will need it, especially if they're symptomatic. And if they have fainting of unknown origin, syncope, we typically will need it. Now, we typically will use a dual chamber, especially if we think there's an AV problem. And sometimes we do synchronization therapy with a pacemaker. Now, for the CRT device, we typically reserve it for patients, we typically reserve it for patients with NYHA 3 or 4, or people with QRS greater than 150 milliseconds. So if you have a left bundle branch block on an ECG, and we'll talk about ECG on Saturday, just watch out, you'll really enjoy that. If a person has a left bundle branch block morphology on ECG and their sinus reading, typically we think about that. Okay, so typically any QRS greater than 130, and it's greater than 150, if you don't have a left bundle branch block morphology, they typically will require CRT.
I'll just remember to mention a client that I'm aware of that heart failure was actually meant to upgrade his pacemaker to an high CD capable pacemaker. But for some reason, because of the COVID epidemic, he postponed it, and he was reluctant to have it done in Nigeria, even though it's locally available in Nigeria. And then one day we heard that he slumped and died. And this is someone that was fully active, very active. I think his class symptoms were probably nothing more than class 2 symptoms, even though he has a well-treated heart failure. So what will you say is the role of the high CD?
So the ICD essentially is very important to prevent sudden deaths. And so in patients with ejection fraction less than 35, NYK class 2 or 3, if their ejection fraction less than 35, we typically should have an ICD. So it is an underserved population. We have a lot of patients. Sometimes it could be financial, and sometimes it could just be that the doctor does not know, or doctors don't know it's available, or doctors do not just offer it to them. So you put an ICD. An ICD helps to reduce sudden death, sudden cardiac death. He was just walking and he died. So if they have heart failure and they have ejection fraction less than 35, or a non-ischemic dilated cardiomyopathy, like the patient we presented, the young man with dilated cardiomyopathy with ejection fraction, that man should have an ICD, and that saves life. We've had a patient that had an ICD and nothing happened. It did not shock the person for almost 5 years. In the 5th year, he shocked. It meant that time that patient would have died suddenly. And everybody would have said, he was fine yesterday. In the 5th year, he shocked and he had to come back, And you can imagine that would have been death. And it has saved him, and he's still alive now. He's still coming from medications. So typically this way, and especially anybody that survives a cardiac arrest. We had a patient that was put in last week, had 2-3 cardiac arrests, before referral to Cardiocare, and immediately we saw that he fit all the classification, LBB type, QRS was prolonged, and then we went in and put in a CRT. He's very fine now. In fact, our NYK class has reduced, and she's on her way home.
Okay, just before we round up, we talked about the HANIs earlier, the angiotensin receptor neprilysin inhibitors. What changes have these drugs brought in the management of heart failure?
So the changes of this drug, and the most common one is one done by Pfizer, I think, Imperial, is massive. It's quite revolutionary. We've seen quite a number of patients get some significant improvement, both symptomatically, ejection fraction wise, on echo, BMP wise. So you can also use the BMP to follow up. If you use the BMP, there are things that you check, and patients have really gotten some improvement. The problem, however, is that knowing when to start and how to start. So sometimes you may need to have a specialist, implement that starting, or do it in conjunction with a specialist.
Even though it was on the screen, I also want you to mention for our audience the beta blockers that are relevant to heart failure. Can they use propranolol, atenolol, or enilolol? That's one. And then secondly, the precautions, so that I don't hear that people are, misusing beta blockers in heart failure tomorrow.
All right, so a lot of times we say beta blocker in heart failure, and then we start simple propranolol. No. The definition of beta blockers in heart failure has 2 components to define. Number 1, their intrinsic sympathomimetic ability, and number 2, their membrane stabilizing activity. So 3 or 4 rather, beta blockers are particularly useful. metoprolol, and not just metoprolol, the short-acting, metoprolol long-acting. So metoprolol succinate. Okay, typically brand name Betaloc. Then we have carvedilol, typically used twice a day, and then bisoprolol. Nebivolol has also been used, so all four of them. So BC, Meta, and they all enter into a car, carvedilol. Okay, and then they will never die, nebivolol. So if you think of those four, so not propranolol, propranolol will worsen heart failure. Atenolol also in most cases will worsen heart failure. In some cases it may be equivocal, but it's preferable not to use. And these are those four I've said are the ones that have been proven to dramatically, by over 30%, change mortality, morbidity from heart failure, reduce heart failure related admissions, heart attack, sudden cardiac death and all.
Thank you very much. Thank you very much for that. Thank you for the discussion. I think we should take some of the questions from our audience now because of time. We respect our people's time. So I'll start with the first question on the menu. Can you please explain why heart failure, especially DCM, is common at a younger age in this part of the world? Why is DCM more common at a younger age?
So it's difficult to say that's the truth of the matter because I'm a scientist and there are no studies to show that.
Yeah.
One of the things that is very important to do is to look at endomyocardial biopsies or at autopsies to look at their heart. But one of the postulations that have been brought about is viruses.
Absolutely.
Viruses got getting at an early age. There was a young girl we managed many years ago when I was doing my residency. She had recurrent exanthems, looking like rash on her chest, and then anytime she has the chest, the exanthem, the heart function was worsening, till she came in and there was really nothing we could do for her. So those viral illnesses are some of the things that have been postulated. Some toxins in the air and in food have also been postulated. There were times when people considered the role of certain toxins in certain foods, gari and whatever. None of them eventually held up, but and then alcohol, of course, yes, alcohol plays a very big role. The amount of people drinking alcohol, and of course, the alcohol adverts are everywhere. Even when you're watching Champions League, there's alcohol that is everywhere, and then people drink a lot of alcohol, and that can also cause problems, especially people that have already a susceptible heart.
Okay, so the summary is that we don't know, but that infectious diseases that are common in this part of the world may actually play a role. So someone is asking, how do we measure JVP?
Now, that's a very difficult question to demonstrate over the internet. But however, essentially, put the patient in 45 degrees angle while lying down. Turn the head to one side and look between the two heads of the sternocleidomastoid with the imaginary line from that going to the corner of the jaw. Now look on that line and try and look for double pulsation at that level. If you cannot see it very well, take your pen touch, and this is for those in residency. You must do that, otherwise you will not pass. Take your pen touch and shine it at an angle. It typically will throw a shadow and you can see that double pulsation. Sometimes in most patients in heart failure, it is so high that they have to sit up before you can see it. Now, in addition to that, the hepatojugular reflux also helps to help you confirm that this is JVP.
Okay, of course, you measure it above the level of the angle of Lewis. By the time you are seeing the JVP, anything in the above a few centimeters of the neck upwards, it is definitely elevated, and you don't see it in most normal people. Another question asks, what's the role of Framingham criteria in the diagnosis of heart failure? Are there other diagnostic criteria?
So yes, Framingham criteria is very important, and it's one of the most important criteria. There's Boston's criteria, the other criteria, but a lot of them are very complex to use, and Framingham criteria is most of these are still very very research based.
Absolutely.
And you cannot start using Framingham criteria in your clinic. But if you have a problem with that, if you start with it, it could be very helpful. Put it on your phone, put your symptoms, and check. And you will be able to, after you've done it for 3-4 patients, it will enter your system and you'll be sure how to differentiate heart failure from others.
Okay, so there's a question here on how can you prevent heart failure in a person with hypertension. I think I'll take that. Hypertension is one of the leading causes of heart failure in Nigeria, and the most important thing we can do by far, we know already, is to control the blood pressure. Control the blood pressure consistently. If you do that consistently, you can greatly reduce the chance of person having heart failure. Of course, it can still happen. If someone lives up to 90 years with hypertension, the heart can fail. Okay, but we'll make it much more difficult for that to happen. And we should fully evaluate our patients. So, if they're developing arrhythmias, even ventricular thickening at some point early, and that's why the argument that everybody with hypertension should have an echo done. So, if we pick those kind of things early, it helps us to modulate the treatment such that any structural changes in the heart does not go on to develop to heart failure or electrical changes. So,
in addition, don't forget diabetes.
absolutely.
Don't forget cholesterol.
Absolutely.
If you take care of all of them together, then the patient is less likely. Also, don't forget that one of the key things that most patients that we want to start on antihypertensives typically try and put an AC inhibitor on ARB. It tends to help remodeling and reversing some of the myocardial injury that could have already occurred before the patient came to you, especially if the patient has a left ventricular hypertrophy.
We should not forget treat to targets. Not you're treating someone on 3 drugs, or the blood pressure is still 160 or something, the job is not complete yet. So the question here is, in managing heart failure, does the diet and salt control matter?
Yes, it does. It matters very significantly. I say one of the precipitants that could precipitate heart failure. You eat anyhow and a lot of salt, take alcohol, it will definitely affect heart failure. It definitely affect presentation, affects, it matters a lot in short.
Absolutely. So usually someone on treatment for heart failure should be on virtually zero added salt diet and should just go for the amount of sodium in the natural food. And usually, of course, they should see a dietitian which will guide them in how to maintain the sodium, amount of water they should take, and how to pay attention to potassium as well. A question here says that how do we manage a patient with a very low blood pressure, like 80/60 or less, seeing the issue with fluid therapy?
Okay, so now, thank you very much. Now, the tendency for a lot of doctors to see, hey, the blood pressure is low, give fluid, is one that must be avoided.
Absolutely.
Once somebody's blood pressure is low, you need to evaluate. If you think that patient has heart failure, fluid is not the way to go. Why?
Absolutely.
Why? The answer is that because the low blood pressure is not caused by fluid deficiency. The low blood pressure in that case is caused by, the heart not being able to, so it's cardiogenic in origin. Giving extra fluid will worsen the preload and make sure that the heart cannot even pump. So when you give more fluid, the blood pressure will go down lower, pulmonary edema will worsen, and that patient will die. Right. The ideal thing you should do, of course, I told you in this kind of situation, a specialist is required, and the ideal thing you should do is to admit that patient and then, put in a line. So if you have a good ICU, put in the line, connect it to your monitor, look at the central venous pressure, and use that to titrate to know how much fluid, especially if the patient needs fluid, maybe they have diarrhea at the same time.
Can actually need fluid.
Now, at the same time, you may now begin, you need to still start those drugs we're talking about. They may bring down the blood pressure, but you must start them.
And that's why they're on admission.
That's why they're on admission. So you manage them. When you start those drugs, as the heart starts improving, the blood pressure will start going back up. So it's about treating with principles, but you must do it carefully and preferably under the guidance of a specialist.
Okay, so the question, I can see a question that a diagnosis of impending heart failure has often been made by some physicians. What can we say about this?
Okay. Impending heart failure. So it used to be something that used to make us laugh, whether the patient has heart failure or not. But however, impending heart failure is heart failure. According to the American College of Cardiology, American College of Cardiology guidelines, the classification of heart failure has been expanded to stage people that have risk factors for heart failure as stage B. So patients have not developed symptoms, but they have hypertension, diabetes. According to American Heart Association, you already have heart failure stage B because you are at risk. Your left ventricle is already hypertrophied, and you have hypertension, or is dilated, and you don't yet have features of heart failure. BNP is not yet raised. As far as we are concerned, you are stage B heart failure. So in that case, yes. So that's what you say.
Okay, some of the questions in the chat box.
Some people are asking about materials. Yes, we will send you some materials afterwards. So don't worry. And then we'll also send you the link where you can watch the presentations.
Is the treatment of heart failure lifelong? Yes, generally speaking, for chronic heart failure, the treatment is lifelong.
Except there are some instances where you may be, and that is typically peripartum cardio.
Thyroid sometimes.
Yeah, and thyroid. So a lot of times, if you manage the thyroid, they might get better. If you manage peripartum, almost 80 to 90% of patients with peripartum get better. And the studies done by Kara et al. In Kanu, and there's a nationwide study has shown a lot of people get back to almost normal cardiac function, and so they may not need continued therapy. Although some people still believe that even if it's low dose spironolactone, they may need to continue it to prevent recurrence.
Okay. Some of the other questions. How do we treat the neurohormonal abnormalities? I think you've mentioned those. Yeah. The RAS is blocked by the ACE inhibitors, ARBs, and the HANIs. The mineralocorticoid is blocked by the spironolactone, and the sympathetic system is blocked by the beta blocker. Is beta blocker for all forms of heart failure?
Yes, so beta blocker is typically for all forms of heart failure based on the new guidelines. Except, of course, there are contraindications. So sometimes severe asthma is not a contraindication, but maybe you're unable to manage it. Sometimes if there's a significant AV block, left bundle branch block, sometimes you may not be able to start it. And in that case, you need to start it under a specialist guidance.
Device. Okay, so device. How much does device therapy cost?
So device therapy essentially is costly. It typically costs between, depending on the type of device. So pacemakers are typically much cheaper. So just plain pacemakers, when patient's heart is very slow, are typically much cheaper, maybe between 1.5 million thereabout. Now, devices like ICD, which typically prolong life, and CRTs, which also prolong life and improve cardiac function, essentially cost much more, typically between 4 and 7 million, depending on the subtype, whether it is MRI compatible and some other things, you know.
Absolutely. And of course, availability, the devices are available, okay? Usually just affordability and the cost of the patient that can be the issue, but the devices are available. And can a patient with diabetes have device placed in? Why not?
Of course.
People sometimes have concerns with wound healing in diabetes, but we should know that once the glycemic control is good, and so that is not. How can we take care of a patient with hypertension with persistent bradycardia?
Okay, so if a patient has hypertension with persistent bradycardia, what you need to do in that case is to evaluate. Number one, you need to evaluate the thyroid function. Number two, you need to evaluate the kidney function. Those are things that could cause the heart to be slow. Then, of course, you need to do an ECG. What is the cause of the bradycardia? Sometimes when you do an ECG, you will see it right there. In other times, you may not be able to tell, and what you have to do is to do a Holter ECG. When you do a Holter 24 hours, 48 hours, so you can get that done in most specialist hospitals like Cardiocare. When you do that, you could find sometimes reasons why, or you could find whereby patient is symptomatic and is having problems, or you could find places where the heart actually almost stops. Cardiac, what we call sinus pauses. And if you have a certain number of sinus pauses, you probably have to put in a device. You need to put a device because the patient could just drop one day.
When can we refer for heart transplants?
So heart transplant is currently not available in Nigeria, and it's also scarcely available in most parts of the world anyways. You know, there's a heart waiting list and all of that. But what we do in Nigeria and can be done in centers like this is essentially to put in left ventricular assist devices, to put in CRT devices, to put in LVADs, or to put in an intra-aortic balloon pump as a bridge, you know, to help the heart recover, especially if it's in an active situation.
Someone asked, can beta blockers be used? I'm not even sure I get the question very well. Can beta blockers be used in breastfeeding women?
Yes, in most cases, beta blockers can be used in breastfeeding women. Of course, you know, you have to weigh the benefit and the risk. Typically, talk to a pediatrician as well. You know, like I said, it's a multi-modality management, so you should also talk with other people.
What is responsible for sudden cardiac arrest in athletes?
Okay, that is typically not in relation to heart failure, but typically most times it could be either a channelopathy, an arrhythmia. So patients could have an inherent abnormality in their electrical reading. So if you look at their normal ECG, you could find some of them having these abnormalities. Or if you look at their stress exercise history before they joined up, hopefully they do a medical before they start, you could find those abnormalities and you could tell them they don't have to understand. Then number two is hypertrophic cardiomyopathy. Some patients have hypertrophic cardiomyopathy, which is there, they did not know about it, and they go on to exercise. Okay, and that could sometimes happen. And sometimes also there are other causes, which would be neurological or otherwise.
Okay, I think we've taken enough, and I think we've had a good session. Dr. Iseko, you've been very wonderful on this session. I hope that our audience were able to pick quite a few things that will improve their practice. And of course, heart failure is a big topic. It's something we can talk about for an entire day without covering it. So this is just some snippets of it. If you have questions, we can ask it in the Cardiovascular Symposium group on WhatsApp, or send us questions by email. We'll be happy to reply to them, even if it takes a little bit of time to do that. And I would like to inform us that tomorrow we'll be taking some interesting topics, including hypertensive crisis, resistant hypertension, that's taken together. And also we'll be going over stroke with Dr. Kennedy, our consultant neurologist as well. So I hope you find time to make it a day with us tomorrow so that we can learn more and discuss this as well.
So tomorrow is by 4 o'clock, just like we started today. We also use this kind of format. It will be very enlightening. I'm sure you will enjoy it. We've had over 100 and almost 180 people joining us from different parts of the country. I'm sure it was worth your time. Tomorrow, we're also going to delve into a lot of things. Abuja Cardiovascular Symposium is run by Cardiocare. Tomorrow also, Cardiocare is going to be officially launching its cath lab. We're expecting the Minister of Health. We're expecting some ministers to come. We're expecting the TV station. So we should be. Thank you very much for attending. If you're in the area, especially if you're a cardiologist, we would like to have you pop in so that we can talk in a little bit. Talk about some things. There is a WhatsApp group, which if you send your phone number to the email address that sent you the mail, you will easily